Welcome to the deep dive. We are jumping straight in today, no fluff, no lengthy intros. You are resident, you are preparing for board exams like the FRCS in plastic surgery, and you do not have time to waste.
Exactly. We know you're busy.
So we're taking a stack of your trauma notes, specifically the upper limb protocols, and we are giving you a high-yield, rapid-fire revision session hosted by two plastic surgeons who have been exactly where you are.
Yeah, we've sweat through these same exams.
Before we get into the trenches, do us a quick favor and press follow so you get more of these revision deep dives. And rate the show if you actually learned something valuable today.
Please do.
Also, you need to get a premium subscription to access the Journal Club and the clinical cases deep dives. Just go do that now so you have the full arsenal.
Because today's mission is absolute mastery.
Right. We are locking down the exact protocols, the indications, and the step-by-step surgical choreography for replantation and revascularization of the upper limb.
Which is, let's be honest, it's the absolute definition of a high-stakes surgical battlefield.
It really is.
The math of a simple elective procedure completely goes out the window when you're staring at a severed limb. You are fighting an active biological clock from the very second that injury happens.
Okay, let's unpack this battlefield. Because before we even scrub in, before we decide how to operate, we have to definitively classify the injury. We need to figure out exactly how much time we have. And the notes are very strict on terminology here.
They are. And for the FRCS, you absolutely must be precise with your definitions. So, replantation is the reattachment of totally amputated parts.
Meaning the part is completely severed from the body. It's in a bag.
Right, completely off. Revascularization, on the other hand, is the repair of incomplete amputations.
So there's still a physical connection.
Yeah, exactly. Maybe a bridge of skin, maybe a crushed tendon.
Yeah.
But the vascular supply is critically compromised and needs restoration.
Total separation versus incomplete separation. Got it. But the ischemic clock we're fighting isn't just based on whether the part is, dangling by a thread or fully detached.
No, not at all.
It's entirely dependent on the specific type of tissue we're trying to save. Which brings us to a massive distinction in the protocols, macro-replantation versus micro-replantation.
This is the physiological divide that dictates your entire timeline. And the defining factor here is muscle bulk.
Muscle bulk.
Right. Macro-replantation involves amputated parts that contain muscle tissue. So think of an amputation at the forearm or the elbow.
Because muscle is just incredibly metabolically demanding, right?
Exactly. It requires massive amounts of oxygen and ATP just to maintain its cellular resting state. Because of this, it is highly sensitive to ischemia.
Okay.
If you're dealing with a macro-replant, that muscle tissue will begin to undergo irreversible necrosis after just 6 hours of warm ischemia, or 12 hours of cold ischemia.
Let me make sure we're crystal clear on this. Macro-replantation is essentially a ticking time bomb because muscle is like a high-energy engine. It just catastrophically fails without constant fuel.
That's a great way to look at it.
Whereas the digits we deal with in micro-replantation are low-energy structures. So if a patient presents with an arm completely off, are we strictly locked into a 6-hour window at room temperature before irreversible muscle death?
Yes. That 6-hour warm ischemia window for macro-replantation is a hard physiological wall. Beyond that point at room temperature, the cellular pumps fail, the cells swell, and the tissue is just dead.
Wow.
Now contrast that with micro-replantation. Here, the amputated parts are usually digits. There is zero muscle bulk in a finger. It's entirely skin, bone, tendon, and neurovascular structures.
And because they lack that demanding muscle tissue, digits are way more resilient.
Way more. They tolerate at least 12 hours of warm ischemia or up to 24 hours of cold ischemia.
Wait, 24 hours? So a severed finger can theoretically sit properly cooled on ice for a full day and night, and we could still successfully replant it?
Theoretically, yes. It completely changes the urgency and the logistics of your trauma response.
It changes everything. But, understanding those time limits only dictates the physiological possibility of surgery.
Right. The next phase of your exam in your actual clinical practice is the decision matrix. Just because you can beat the clock physiologically doesn't mean a 14-hour microvascular surgery is the right choice for the human being on the table.
And this is exactly where the examiners want to test your clinical judgment. Not just your memorization of times. The first rule, before any anatomical consideration, is managing patient expectations.
Absolutely paramount.
Yeah.
You have to have a very frank discussion about what the patient actually wants. Replantation means a grueling surgery, months of intense, painful rehab, and the very real potential for long-term stiffness or severe cold intolerance.
It's not a magic fix.
Not at all. Many patients, when presented with that reality, actually opt for terminalization.
Terminalization being essentially completing the amputation, cleaning up the bone, and closing the sump for a faster recovery.
Exactly. They choose that because it lets them get back to their baseline life and work without a year of rehab.
But let's assume the patient is fully on board for the long haul. We evaluate the relative indications. The protocols give us specific green lights. We're looking at the thumb, right?
Always a thumb, purely because of its critical role in opposition.
Yeah.
You lose the thumb, you lose most of your hand function,
What else?
multiple digits, any amputation through the palm, almost any amputated part in a child because their neuroplasticity and regenerative capacity are so robust.
Right.
Amputations at the wrist, forearm, elbow, and above the elbow. Also, a single digit if the amputation is distal to the flexor digitorum superficialis, the FDS insertion.
BFDS insertion, got it.
And finally, patients who absolutely require a 10-digit hand for their livelihood, like concert musicians.
Okay, those are your relative indications. But the red lights, the relative contraindications, are where you really need to be sharp for the boards. This is where you have to look closely at the mechanism of injury.
Yeah, let's talk about avulsion injuries, because these are high-yield exam gold. We aren't talking about a clean guillotine cut from a paper slicer. We're talking about a limb caught in a rotating machine where the structures are stretched and torn.
Brutal injuries. What specific clinical signs are we looking for on the amputated part?
You're looking for two specific telltale signs that scream severe traction trauma to the vessels. First is the red streak sign.
Right streak sign.
Right. This presents as a linear hematoma. It's basically bruising seen directly through the skin over the neurovascular pedicle.
And what does that tell us mechanistically?
It tells you the vessel has been violently stretched to the point that the vasa vasorum, the tiny blood vessels that supply the artery wall itself, have ruptured and hemorrhaged all along its length.
So it's essentially internal bleeding along the pipeline itself. And the second sign?
The second is the ribbon sign. When you examine the vessels under the microscope, they have this tortuous corkscrew appearance.
Like a ribbon.
Exactly. This visual cue tells you that the intima, the delicate inner lining of the vessel, has been stretched, shredded, and coiled up inside the lumen.
Which is a disaster for microvascular repair.
A total disaster. If you try to anastomose a clean vessel to a segment showing a ribbon sign, that shredded intima acts like a microscopic net. It'll catch the platelets and thrombose completely.
So if you see a ribbon sign, that vessel is a destroyed pipeline. You have to resect it back to healthy tissue no matter how much length you lose.
Exactly.
Other relative contraindications in your notes includes severely crushed or mangled parts, amputations at multiple levels like a limb run over by a train, extreme contamination, prolonged ischemia, severe atherosclerosis, mental instability, and importantly, a single-digit amputated proximal to the FDS insertion.
Which perfectly brings us to ring avulsions. Classified by Urbaniak, this is classic board material because it combines traction injury with very specific functional outcomes.
Let's set the scenario. A patient jumps a chain-link fence, their wedding band catches on the top wire, and their entire body weight drops while the ring anchors the finger. The sheer force strips the tissue. How does the Urbaniak classification break this down physiologically?
Well, Urbaniak Class 1 is the best-case scenario of a bad situation. The soft tissue is stripped, maybe the skin is degloved, but miraculously, the circulation remains adequate.
The vessel's stretched but didn't snap.
Right. But Class 2 is where the structural integrity fails. Circulation is inadequate, meaning the digit is ischemic, and you must perform microvascular reconstruction to restore perfusion.
And you'll see Class 2 subdivided in the literature based on exactly what snapped.
Yes. Class IA means only the digital arteries require repair. Class IAB is a massive escalation. It means the arteries plus the bone, tendon, or nerves are structurally compromised.
And Class II?
Class IA means the arteries survived, but the delicate veins were completely shredded and require repair.
And then we hit Class 3, the nightmare scenario. Complete degloving or a complete amputation of the digit.
Yeah, and the notes are very specific here. If a Class 3 injury is proximal to the FDS insertion, it has a terrible prognosis and is best terminalized.
You might only attempt replantation if it's distal to the FDS, and only if the PIPJ, the proximal interphalangeal joint, and the proximal phalanx are perfectly intact.
Right, because if you replant a finger proximal to the FDS, the flexor tendons are severely damaged in a zone that is notorious for scarring. The patient ends up with a finger that has blood flow, but it's a stiff, immobile peg that actually gets in the way of their healthy fingers.
Okay, here's where it gets complicated for a resident in an exam. Let's combine the rules. A professional pianist catches their ring on a fence. They suffer an Urbaniac Class 3 complete amputation of their single index finger, and it is proximal to the FDS.
Oh, that's a tough one.
Right. This hits a strict indication. They are a musician who needs 10 digits, but it also hits a strict contraindication, a single digit proximal to the FDS with an avulsion mechanism. How does the protocol resolve conflicting physiological constraints versus patient demands?
This is a fantastic question, and it's exactly what examiners want to see you navigate. Guidelines are relative, not absolute.
So what's the textbook answer?
The physiological constraint, a guaranteed poor functional outcome for an avulsed single-digit replanted proximal to the FDS, usually dictates that terminalization is safer. A stiff, painful index finger will just be bypassed by the brain.
They'll stop using it.
Exactly. However, the specialized occupation clause acknowledges that for this specific patient, even a bypassed stiff digit might be absolutely crucial just for resting on a piano key.
So what does this mean for your exam answer?
You explain the incredibly high risk of stiffness and failure to the patient. You lay out the biology. But the ultimate decision leans heavily on their occupational demand. You attempt the replant, knowing the functional ceiling is very low, because that low function is still better for their career than an absent digit.
The art of surgery, perfectly balancing the science. I love it. Okay, let's assume the decision is made. We are going in. This shifts us to pre-op logistics and the two-team surgical strategy. The clock is ticking. The notes outline very specific protocols for transporting the amputated part.
They do.
A junior resident might think, get it cold as fast as possible, throw it in a cup of ice. Why is that the exact wrong move?
Because direct contact with ice will cause frostbite. The water inside the cells of the amputated part will crystallize, expand, and shatter the cell membranes from the inside out. You'll literally destroy the tissue you're trying to save.
And not to mention severe maceration of the skin.
Yeah.
So what is the board-approved protocol?
Wrap the part in Mohs gauze. Place that wrapped part into a sealed, watertight plastic bag or container. Then put that sealed container into a second container filled with a slurry of ice and water.
Keep it cool, prevent freezing. Moist gauze, sealed bag, ice water, slurry. The triple layer, perfect.
Exactly.
Now, once the patient and the part are in the hospital, we deploy the two-team approach to beat that ischemia clock. Let's break down the choreography. Team 1 is working on the amputated part.
Yes. Team 1 is in theater, working essentially on a back table while the patient is being prepped. First, they plan the osteosynthesis via X-rays. They debride the part to remove contaminated tissue.
And for exposure.
To get good exposure of the tiny vessels and nerves, they use longitudinal midaxial incisions along the sides of the digit.
And then comes a step that the textbooks highlight in bold: bone shortening. They deliberately cut away healthy bone on the amputated part, and they insert the distal half of the bony fixation K-wires, interosseous wires, or mini plates in advance.
Meanwhile, Team 2 is working directly on the patient's stump. They debride the stump, isolate and tag their ends of the neurovascular structures, shorten the bone on their side, and then begin the sequence of repairs.
Let's run through that sequence.
First, they fix the bone. Then repair the extensor tendons, then flexor tendons. Next, they anastomose the arteries, culpit the nerves, anastomose the veins, and finally achieve skin cover.
So essentially, Team 1 is prepping the replacement part on the workbench, drilling the pilot holes, and setting the hardware, while Team 2 preps the main chassis.
That's a great analogy.
But let's go back to the bone shortening. Why is cutting away healthy bones stressed as such a vital step for both teams?
Because tension is your absolute worst enemy in microvascular surgery. Imagine trying to sew two wet noodles together while someone is pulling them apart.
Sounds impossible.
It is. If you try to anastomose a tiny 1 millimeter digital artery under even a millimeter of tension, the vessel will spasm, the sutures will tear through the intima, and it will clot instantly.
So by deliberately shortening the bone, you are artificially creating slack in the surrounding soft tissues.
Precisely. That slack allows you to perform primary, tension-free repairs of the arteries, veins, and nerves without needing to harvest interposition grafts right off the bat.
But even with aggressive bone shortening, we still face microvascular chaos. The teams are perfectly synchronized, the bones are fixed, but now the surgeon faces the most common point of failure: inadequate vessels and massive venous congestion.
Right. Sometimes primary repair just isn't possible.
Yeah.
The zone of injury from an avulsion might be so wide that the vessels are destroyed over several centimeters.
In these cases, you require interposition vein grafts to bridge the gap, Or you might have to transpose a vessel from an adjacent healthy finger.
And your notes highlight a very specific, high-yield graft option, volar wrist grafts.
Ah, yes.
Vein grafts taken from the volar aspect of the wrist perfectly match the anatomical caliber of digital arteries. And the neat trick is you can place them extra anatomically, routing them directly over the hand to plug into the radial artery at the wrist if the local arteries are totally destroyed.
But the arteries are only half the battle. Arteries are thick-walled, muscular, and pump under high pressure. Veins are thin-walled, floppy, and incredibly fragile. After a crush or avulsion, finding intact veins for outflow is so difficult.
It really is.
Which brings us to the nightmare scenario. You've fixed the bone, you've sutured the artery, blood is pumping into the finger, but the veins are absolute mush. The digit starts swelling, turning dark purple, and dying of venous congestion.
The protocol lists 5 distinct salvage techniques to save the replant when standard venous drainage fails.
Let's hit them. What's salvage number 1?
Salvage number 1.
Right.
You meticulously search for and repair any volar veins you can find on the palm side of the digit, even if they aren't the primary dorsal veins you usually target.
And if those are all destroyed?
Salvage number 2. Creating an arteriovenous fistula. You take a redundant digital artery 1 that has retrograde flow, and you anastomose it directly to a larger intact vein.
Wait, let's look at the physics here. Creating an AV fistula means connecting a high-pressure digital artery directly into a low-pressure vein. That sounds completely counterintuitive to basic plumbing. Why does intentionally creating a fistula serve as a backup for venous drainage?
It sounds crazy, I know. But what's fascinating is you are actively using the body's own arterial driving pressure to solve a venous block.
How so?
If the normal venous pathways are crushed, the digit swells with blood until the pressure chokes off the arterial inflow and the digit dies. By connecting a digital artery that has retrograde flow directly into a larger functional vein proximal to the injury, you are effectively using the heart's arterial pressure to force a new drainage pathway open.
Oh, wow.
Yeah, you are pushing the congested blood out of the digit and back into the systemic circulation. It's a high-pressure flush for a low-pressure plumbing problem.
Brilliant. Using the engine to clear the exhaust. Okay, salvage number 3.
Removing the nail plate entirely and scraping the sterile matrix underneath to encourage raw bleeding, then wrapping it with heparin-soaked gauze to stop it from clotting.
You're basically turning the entire nail bed into an artificial external vein, letting it slowly bleed out into the dressing to relieve the internal congestion.
Exactly. Controlled bleeding to save the tissue. Salvage number 4 is a variation of that, making small stab incisions in the periungual area, right around the borders of the nail, and applying topical heparin to keep those stab wounds continuously bleeding.
And finally, salvage number 5, medical leeches. Which isn't medieval medicine, this is highly specific pharmacology.
It is. Leeches do 2 things. First, they provide a mechanical vacuum to drain the congested venous blood. Second, they secrete hirudin into the bite wound.
Hirudin?
Right. It's a powerful natural anticoagulant that keeps the wound oozing venous blood long after the leech has dropped off, providing continuous decompression of the digit.
Amazing. So we've solved the delicate microvascular puzzles of digital replants, but the protocol shifts dramatically when we scale up to macro replantation. Dealing with proximal amputations, like an arm severed above the elbow, involves heavy muscle bellies. That changes the entire surgical sequence.
The scale of risk massively increases. The absolute priority shifts entirely away from the bone.
It's no longer about meticulous bone fixation first.
No, the sole priority is establishing arterial inflow immediately to stop the muscle from undergoing necrosis.
To achieve this, the notes state you use a temporary vascular shunt, specifically a sunt, Pruitt Inahara or Javid shunt. So instead of carefully plating the humerus, you are grabbing medical tubing, plugging one end into the patient's pulsing artery, and plugging the other end into the severed arm's artery, bypassing the entire anatomical gap to get oxygenated blood flowing into that dying muscle before you even look at the bones.
Exactly. You buy yourself time. Once the muscle is perfusing and turning pink through the shunt, then you proceed with the considerable bone shortening, which is mandatory when amputating through muscle bellies.
Got it. So the bone fixation is done prior to definitive arterial repair, but while the temporary shunt is doing the physiological work.
Precisely.
But here's where the macro replantation protocol gets incredibly dangerous. You've restored arterial flow to muscle that has been ischemic for hours. That muscle is full of dead cells and accumulated toxic metabolites.
This is the reperfusion injury phase. You cannot just let that venous blood return to the patient's systemic circulation.
Because when ischemic muscle cells burst, they release massive amounts of potassium, myoglobin, and lactic acid.
Right. The protocol explicitly states that the venous blood must be drained from the amputated part for a period of time to flush those toxins. You literally unclamp the vein and let the venous return bleed out entirely onto the operating table.
Wait, so we establish a temporary arterial shunt to pump the patient's own blood into the arm to keep it alive, but deliberately bleed the returning blood out into a suction canister to flush toxins. We are effectively requiring a massive blood transfusion just to keep the patient from bleeding out on the table.
Yeah.
Are we intentionally causing major blood loss just to save the limb?
We absolutely are. It is a literal choice between life and limb. We intentionally bleed the limb out and replace that lost volume with a clean, systemic blood transfusion to protect the patient's heart and kidneys.
Because if you let that hyperkalemic sludge hit the right atrium, you invite massive systemic shock and cardiac arrest.
Exactly. Protect the patient first, salvage the arm second.
It is a massive physiological toll. And it doesn't end there. Fasciotomies are always indicated in macro replants because that reperfused muscle will swell massively.
Always. Without opening the fascial compartments, the muscle will just crush its own blood supply.
Plus, the surgeon must take the patient back for a second look under general anesthesia within 48 to 72 hours, just to assess for further hidden muscle necrosis.
The physiological violence of macro replantation cannot be overstated.
Which brings us to the end of our protocol revision and a broader clinical reality for you to consider as future attending surgeons. We want to hear from you out there. Leave a comment or a question about your own experiences studying these protocols or difficult cases you've seen in the trauma day.
Yeah, we'd love to hear from you.
And a quick reminder before we go, press follow so you don't miss our next revision session. Rate the show if this helped clarify your notes, and sign up for the premium subscription to access the clinical cases and journal club.
Knowledge is most valuable when you understand the why behind the protocol.
Exactly. But before we sign off, here's a thought that your textbooks rarely answer. We just spent this entire session figuring out the exact plumbing, the bone shortening, and the toxic flushes required to successfully reattach a limb. But considering the grueling years of rehab, the chronic pain, and the severe stiffness that so often follows these heroic microvascular marathons,
It's a tough road.
at what point is our surgical success actually a worse functional outcome for the patient than a clean terminal amputation and a highly advanced, well-fitted prosthesis? Think about that for your next shift.